So then we'll move on to the lecture 3 is novel strategies in bronchiectasis management. It's going to be delivered by Dr. Janet Stowell, BSc, MBBS, PhD, FRCP. She's a consultant respiratory physician and Host Defense Department, Royal Brompton Hospital, and Guy's and St. Thomas NHS Foundation Trust, UK. And Dr. Stowell is a specialist in respiratory infections and host defense with particular expertise in diagnosis and management of bronchiectasis, non-tuberculous microbacterial disease, primary immunodeficiency, and other complex respiratory infection. Now we will listen to the recorded speech by Dr. Stowell. And she will be available for questions at the end.
Speak as part of Bronchiectasis 360. I have no conflicts of interest. So I've been asked to talk about novel strategies in bronchiectasis management. Bronchiectasis management has shifted from simply treating symptoms as they present to phenotype and endotype disease-modifying therapies. It is without doubt a very exciting time in the field of bronchiectasis. Recent breakthroughs focus on reducing neutrophil and eosinophil-driven inflammation, optimizing microbiome-guided antimicrobial selection, and applying bespoke mucus-clearing techniques. So in this talk, we will look at the role of long-term macrolides, inhaled antibiotics, DPP-1 inhibitors and their impact on neutrophil inflammation, eosinophilic bronchiectasis and targeted biologic therapies, and briefly touch upon precision medicine and future therapies. So I showed this slide for the first time many years ago because at Brompton we always have been interested in the different etiologies of our cohort of bronchiectasis patients. And there are reasons for this, which have become more apparent in recent years as we realise that endotype and phenotype are all important in influencing treatment response. Emerging therapies targeting specific inflammatory pathways show promise for more precise treatment of bronchiectasis based on inflammatory phenotype. The concept of treatable traits, which we have seen develop for asthma and now COPD, are also applicable to bronchiectasis. The vicious cycle, coined by Brompton Professor Peter Cole back in the 1980s, has developed now into Flume's vicious vortex, which acknowledges the complex interactions between pathophysiological steps and the issue of having to target multiple components in order to break it to achieve treatment effect. And here is a diagrammatic representation of that, describing the self-sustaining cycle where airway dilatation and impaired mucus clearance, chronic infection, and severe inflammation continually feed into one another. The challenge being to target the pathway or pathways which impact most on any particular phenotype. So before we delve into the endotype phenotype possibilities, let's look at where we are with the tried and tested strategy of long-term macrolide use. And this strategy has traditionally been employed for our frequent exacerbators, once airway clearance has been optimized and other associated comorbidities have been addressed. The benefit is believed to be due to both antimicrobial and immunomodulatory effects, which reduce inflammation and mucus production. The 3 landmark studies supporting this, Embrace, Bless, and BAT clinical trials, demonstrated a significant reduction in frequency of infective exacerbation in bronchiectasis patients commenced on long-term erythromycin or azithromycin. But a more recent question posed is, do patients with high symptom burden, but fewer exacerbations, benefit from macrolide therapy in a similar manner? And a pivotal post hoc pooled analysis of these 3 trials using the EMBARC registry revealed that patients with high baseline symptoms benefit from macrolides just as much as those with frequent exacerbations, concluding that symptom severity was as important an indication for long-term macrolide treatment as exacerbation frequency. And just to mention related discussions had at the most recent ERS conference concerning non-macrolide antibiotic maintenance treatment. The panel suggests not to offer long-term non-macrolide oral antibiotics as a first-line treatment to adult patients with bronchiectasis and a high risk of exacerbations, but that they may have a role in specific situations where patients are at high risk of frequent exacerbations, and other options such as long-term macrolides are contraindicated or have proven ineffective. Moving on to inhaled antibiotics, where there's lots of enthusiasm around this as a treatment option to lessen requirement for intravenous therapy in some of our patients. The use of inhaled antibiotics is an alternative that provides consistent deposition of high antibiotic concentrations directly to the site of infection, with a lower risk of toxicity, systemic adverse events, and bacterial resistance. Multiple agents have been trialled: colimycin, gentamicin, tobramycin, aztreonam, meropenem, ciprofloxacin. That's not to say there are no side effects. Bronchospasm, sore throat, and cough can be problematic in some patients, and aminoglycosides tend to be a more likely cause of bronchospasm than other antibiotic classes. Inhaled antibiotics can be used for exacerbation management, in attempted eradication of bacteria such as Pseudomonas aeruginosa, and as maintenance treatment for patients colonised with problem pathogens. However, there has been some historical difficulty in nailing down consistent trial results to inform updated guidelines. And the ERS guidelines back in 2017 made a conditional recommendation to offer inhaled antibiotics to patients with pseudomonal infection with 3 or more exacerbations per year, while recommending oral antibiotic prophylaxis with a macrolide for those without pseud. Subsequent to these guidelines, a series of large phase 3 studies have increased the evidence base quite substantially for inhaled antibiotics. And I have noted them, or some of them, the selection down for you here for reference. To help further with clarity in this area, a recent systematic review and meta-analysis, 20 studies with more than 3,000 patients, concluded that inhaled antibiotics reduced exacerbation frequency, severity of exacerbation, and improved quality of life. Adverse effects were comparable with those of placebo treatment, thus supporting the efficacy and safety of inhaled antibiotics in bronchiectasis. An important finding in this analysis was that despite the apparent inconsistent results between trials of inhaled antibiotic done previously, the results for exacerbations were remarkably consistent, despite differences in study design, also duration and antibiotic used. The true treatment effect determined as somewhere between 16 and 35% reduction in exacerbations, which I think we and our patients would agree is worthy of interest. Why the inconsistency? Quite possibly reflecting individual studies and the powering of such on the basis of much larger effects. Which leads me to the current ERS guidelines recommending offering long-term inhaled antibiotics to patients at high risk of exacerbations and chronic infection with Pseudomonas aeruginosa and with pathogens other than pseud. Those patients deemed to be at high risk of exacerbation include those with a history of 2 or more exacerbations per year in that year prior to assessment, or 1 or more severe exacerbation, or an exacerbation plus severe daily symptoms. Important to remember that inhaled antibiotics should be prescribed for a defined period and treatment response then formally evaluated, such that if ineffective or poorly tolerated, it should be discontinued. I mention now of attempted eradication. Nebulized colomycin, tobramycin, gentamicin have been shown to be effective in Pseudomonas colonized patients. And again, the ERS, they offer eradication treatment to patients with a new isolation of Pseudomonas aeruginosa. That being the first time a patient has isolated Pseud, or a further isolation following a prolonged period during which it wasn't detected. Now, eradication practices vary both among panel members of the ERS in discussion and globally. Some clinicians prescribing systemic antibiotics, usually a 2-week course, followed by a repeat sputum culture and discontinuing those antibiotics if the sputum culture is negative. And others would add inhaled antibiotics for 4 weeks or even 3 months, depending on the choice of agent, without checking sputum or rechecking sputum cultures. And there is little head-to-head data of tobramycin versus colomycin in attempted Pseud eradication. We don't know yet if 1 month tobramycin is equivalent or preferable to the 3 months of colomycin, which we have used at Brompton for some time. 4 of the 6 eradication studies, or the main eradication studies in non-CF bronchiectasis, none of them randomized controlled trials, I should point out, used 3 or more months of colomycin, whilst 2 of them used tobramycin. And there's a meta-analysis from a year or 2 ago, Bronchiectasis and colleagues, suggesting higher eradication rates from a combination of systemic and inhaled antibiotics versus systemic antibiotics alone, but doesn't comment on combined systemic and inhaled versus inhaled alone. Probably, though, the key question to consider is the duration of treatment rather than the choice of antibiotic. And a clinician's approach may well vary depending on whether it's a first growth in a young patient with minimal structural lung disease versus an older patient with significantly damaged lungs who may benefit from treatment of longer duration. Okay, moving on now. I think in the interests of time, I will say this is an exciting breakthrough investigational therapy. I'm sure you're all now familiar with it, bronzocatab. In August 2025, the US FDA approved bronzocatab, a selective dipeptidyl peptidase 1 DPP1 inhibitor, as the first disease-modifying therapy for non-cystic fibrosis bronchiectasis. And bronzocatab works by reducing neutrophil elastase activity and has shown robust efficacy in decreasing exacerbations, marking a major milestone in bronchiectasis treatment options. So just to understand its mechanism a little bit more, neutrophil elastase can be thought of as a cutting enzyme, key to the release of neutrophil extracellular traps or nets, webs of DNA released to trap bacteria, which can be damaging if allowed to accumulate. And in the non-bronchiectasis patient, the healthy individual, this neutrophil elastase is inhibited, kept in check by antiproteases such as alpha-1 antitrypsin. And this feedback loop, which breaks down in bronchiectasis, releasing neutrophil elastase, overpowering this antiprotease activity and resulting in this net formation, mucus production, and reduced clearance through ciliary inhibition, such that blocking neutrophil elastase reduces net formation, allowing neutrophils to be rerouted to a more useful phagocytic role. And it comes in tablet form. It's well tolerated. Once daily treatment with 10 or 25 milligrams, as per the Aspen trial, led to a lower annualized rate of pulmonary exacerbations than placebo. The decline in FEV1 was less with the 25 milligram dose than with placebo. So this is truly big news for bronchiectasis. Now available in the States, in the UK, we're in the process of working out patient eligibility, feasibility of distribution and such like. Okay, moving on to Eosinophilic bronchiectasis, so sticking with the endotype-phenotype concept, it's driving research at the moment. Eosinophilic bronchiectasis is a distinct disease subtype affecting approximately 20% of bronchiectasis patients. Blood eosinophil counts are raised in the absence of concurrent asthma or allergic bronchopulmonary aspergillosis, ABPA. However, blood eosinophils don't necessarily reflect or perfectly reflect airway eosinophilic inflammation. And again, Prof. Chalmers' group has performed a study utilising EMBARK bridge cohort data showing the relationship between eosinophilic airway inflammation, blood eosinophils, and clinical presentation, and how complex it all is. They looked at sputum from 180 patients with stable CT confirmed bronchiectasis, interrogating these sputum samples for a range of eosinophil-generated proteins. Sputum concentrations of some of these proteins, such as galectin-10, eosinophil cationic protein, ECP, and eosinophil-derived neurotoxin, EDN, were weakly but significantly associated with greater radiological severity, a worse lung function, and chronic Pseudomonas aeruginosa infection, also Aspergillus sensitization. And interestingly, airway eosinophil protein concentration did not associate with exacerbation frequency, but total eosinophil protein count or concentration moderately correlated with blood eosinophil count. So what they concluded in all of this is that direct measurement of the eosinophilic airway inflammation provides additional information to blood eosinophil counts and addresses limitations of the conventional sputum cytology approach, which may underestimate eosinophilic inflammation due to cell lysis or poor sputum quality. But again, there are some questions to be explored, some of which are addressed in the various references I've included here. But what is driving the eosinophil activation in a disease which is traditionally framed around chronic infection rather than T2 immunity? And could drugs targeting T2 immunity be usefully employed, as in asthma and COPD? Are the reactive eosinophils friend or foe in terms of fighting infection and their impact on inflammation? Prior work has demonstrated a U-shaped relationship between blood eosinophil count and disease severity, with worse outcomes at very low and very high eosinophil levels, and relative stability in those bronchiectasis patients with moderate counts. So it's important to also realise that many individuals may have a mixed eosinophil neutrophil inflammatory profile. So rather than being a discrete clinical phenotype, is eosinophilic bronchiectasis more of a heterogeneous endotype within a neutrophilic disease framework? This slide gives an overview of the molecular pathways of the T2 endotype with biological drug checkpoints. T2 targeted therapies, including inhaled corticosteroids, have been shown to reduce exacerbations in observational studies, and this phenotype provides a theoretical basis for the future use of biologics targeting eosinophilic inflammation. I'm not going to spend time on this slide because I don't have it, and as you can see, it is an extremely complex series of pathways and interactions. But to give you an idea of which studies are looking at which drugs, we have drugs targeting the IL-5 pathway, such as mepolizumab and benralizumab. There is the Mahali trial, which started investigating the efficacy of benralizumab in non-asthmatic patients with bronchiectasis and this Th2 inflammatory profile. But this was terminated early due to recruitment challenges related to COVID-19 pandemic. But we do know that both mepolizumab and IL-4 receptor targeted dupilumab can reduce exacerbation rates in patients with COPD, which, like bronchiectasis, is associated with the predominance of neutrophilic inflammation. And these findings raise the possibility of similar benefits in bronchiectasis. And then there is tezepelumab, a human monoclonal IgG2 antibody blocking TSLP, thymic stromal lymphopoietin, which importantly does not require a Th2 skewed inflammatory profile for clinical efficacy. So it's implicated not only in type 2 inflammation, but also in mucus hypersecretion and airway remodeling, both being hallmarks of bronchiectasis. And it follows that by reducing mucus plugs and infectious exacerbations, tezepelumab offers a potentially unique advantage to other biologics, given that its efficacy does not depend on the presence of this Th2 high phenotype. I think we'd all agree that the heterogeneity of bronchiectasis necessitates precision medicine approaches tailored to individual patient presentations rather than standardized treatment, the algorithms, the one-size-fits-all approach. Characterizing a patient's inflammatory profile is key to personalized bronchiectasis care. However, determining how endotype manifests as phenotype is challenging, as is the assessment of stability of an established endotype. Can patients go between a neutrophilic and eosinophilic endotype over time? And what's the trigger to change? What's driving what in terms of infection and the inflammatory environment within the airways? Does Pseudomonas drive the eosinophilic endotype, or does the eosinophilic bronchiectasis predispose to infection with Pseudomonas? Another future consideration is utilising biologics used to manage autoimmune conditions such as rheumatoid arthritis or inflammatory bowel disease. This may influence the course of bronchiectasis in patients thought to have the appropriate endotype. And briefly back to brenzocative. Brenzocative, it's not classified as a biologic, but its mechanism of action reflects a broader trend toward the precision targeting of airway inflammation. And looking ahead, the development of anti-neutrophilic biologics specifically designed for bronchiectasis may well be an expanding field. There are multiple further targets to be considered and are indeed in the process of being investigated, and we watch this space. Precision medicine has made rapid strides in the management of asthma, and it is anticipated that similar progress will eventually be achieved in bronchiectasis, but will require continued research, patience, and innovation. Just briefly mentioning CFTR modulators and the role of CFTR defects, because it's interesting, and there's a bunch of studies now showing high frequency ranging from 30 to 40% of CF causing variants in bronchiectasis patients, suggesting a possible etiological implication. Though the clinical implications of CFTR dysfunction in bronchiectasis are difficult to assess due to the diverse range of effects caused by over 2,000 known CFTR variants, some CF causing, others associated with varying clinical consequences, and some with no clinical impact. So the jury's out on whether or not the presence of a CFTR variant is reliably associated with worse respiratory outcomes and clinical severity. However, there's no doubt that elucidating the role of CFTR in bronchiectasis pathogenesis will be potentially critical, especially given the potential for CFTR as a new treatable trait. That concludes my talk for the moment. I will be available to answer questions in the live question and answer session. Thank you.
Okay, thank you very much, Dr. Stowell, for your detailed explanation of novel therapies in bronchiectasis management. It's time for questions. Is available online.
Niranjan, I think nice to see you again. Right, so the question, yeah, hello, good morning. And
just about morning here.
all right, okay. So, right. So I think thank you for your excellent presentation about the novel strategies of bronchiectasis. The question from me is because from the low and middle income countries like us with some low facilities, and sometimes I think we don't have much inhaled antibiotics, and there's very limitation for the biologics. So what is the your practical answer for the respiratory physician in low and middle income countries about managing bronchiectasis patients?
Yeah, it's a really good point, and the concept of geographical variation, not just in the causes of bronchiectasis, as Dr. Dar beautifully talked about, but also what's available treatment-wise. And I think we mustn't forget in all of this that the potential exciting developments and the various different drug opportunities, there's also the basics and the airway clearance that is never going away. The importance of a patient knowing how to clear the airways in a way that works for them to the best of their abilities, in a way that they can manage day to day, and getting prompt treatment, if at all possible, of an infective exacerbation, knowing the microbiology, targeted antibiotics as opposed to broad spectrum, and then the more nuanced treatments that are coming out of all this incredible research are, obviously a significant way off in a sense for countries with limited opportunities there. So, I think pragmatic is the key. Doing what anybody can with the patient in front of them, concentrating and not forgetting about the basics first, and building up from there. I do think Dr. Dar's point about actually understanding the etiology is super important, and it's fascinating to think about the TB impact in India, South Asia, Sub-Saharan Africa, and also the diabetes, because it's something that wouldn't necessarily cross the minds of every physician in Europe looking at their respiratory cohort.
Hello, Dr. Janet. I'm Dr. Lakmini, chest physician from Kennedy Hospital. We have seen a lot of patients with pseudomonas. Despite of eradication regimes, they become chronic colonizers, which is a real challenge. And when it comes to eradication, what is your practice or advice? After IV eradication regime of 2 weeks, do you check the sputums, and if negative only you go for the inhaled antibiotics, or do you directly go into inhaled antibiotics after IV eradication regime? This is a common question I get from my colleagues. Thank you.
So this is a question that has been talked about quite a lot, because different people in different world do different things. But there is good enough evidence now for going straight for the inhaled antibiotic, following on from the systemic treatment. We tend to go for potentially oral ciprofloxacin if the patient isn't that unwell, but we want to get rid of the Pseudomonas, particularly if they're young. The structural lung disease isn't significant. But in your relatively sick, exacerbating Pseudomonas patient, you've identified it, it's something you want to get rid of, we would go for 2 weeks intravenous targeted anti-pseudomonal treatment and straight on to either inhaled colomycin for 3 months, or more recently we've been using the tobramycin 1 month regime. And there's no real head-to-head data on which of those two is the better approach for inhaled. And then I'd have a look at the sputum at the end of that, and we may or may not have been successful, and it may or may not be a sustained success, which is where ongoing repeated sputum monitoring is so important. Does that help?
Good morning. It's very early morning for you, Dr. Janet. I'm Dr. Amit, and thank you for staying with us live. I'm Amit. I'm a senior chest physician from the National Hospital of Sri Lanka. A while ago, we heard Dr. Dal speak about the importance of Klebsiella and regional differences emerging from registry data. It's our experience also that we see Klebsiella as a significant pathogen in patients with bronchiectasis, sometimes with COPD overlaps. Should we treat this, should we use eradication regimes as aggressively as we do for Pseudomonas with Klebsiella? Is there any evidence to suggest that from regional data?
That's a really interesting question. I don't know the right answer yet, but I think it's one of those pathogens that is showing itself to be what I would call a problem pathogen. The data out there is very clear with Pseudomonas that lung function, morbidity, exacerbation frequency is all exacerbated by that particular organism. But I think it's not on its own, and I think Klebsiella is an important one. And I think, again, geographical variation as to where we're seeing what bugs do what damage is another really important development. I think as the research continues, we will come up with more and more of these pathogens, endotypes, etiologies, which need really quite aggressive treatment.
Thank you. Do you think that microaspiration may have a role in these patients where we isolate Klebsiella and other gut organisms?
Yes, absolutely. Yeah, and the whole business of potential microaspiration gut organisms in the lung and what damage they can do, that is a whole other area of research which is going to come out with interesting data, I'm sure. It's a thing, and particularly in the more elderly population, the older people are, and the more the bronchiectasis is diagnosed, picked up and followed through, the more we're going to see those sorts of issues coming to the fore, I think.
Dr. Stowell, for your presentation and your dedication and your time for the questions.